the first episode Psychosis Program panel with us tonight to share their experiences and their expertise. Before we get started with the panel, I want to give a huge shout out to the community. I really want to say we appreciate everything you did to help make our walk an extreme success. We were able to surpass our fundraising goals, and this is so exciting, and we just want to say we appreciate it, and we look forward to continuing to bring our programs to the community over the next year. So thank you so much for that, and with that, we'll take it away with our panel.
Hi, I am Amanda Davis Scott. I am the supervisor of the Turning Point Program, which is the first episode Psychosis Program for Fairfax County.
I'm Lisa Beran. I'm the team lead or the supervisor for the Loudoun County first episode Psychosis Program called LINC.
I'm Dr. Anjali Jindal. I'm a psychiatrist both with the Fairfax County Turning Point Program and the City of Alexandria Trails Program.
And I'm Joanna, and I am the supervisor of the City of Alexandria first episode Psychosis Program Trails.
And I'm Sophia Lenk with Prince William County, the GetOnTrack program. I am the supervisor team lead for that program.
And I know we have Stephanie here too, if she's here to introduce herself, maybe.
Yes. Yes, I'm Stephanie, and I'm a parent of a son who has just is just completing the Turning Point program and has had great success.
Thank you.
So we wanted to give you a little bit of an overview of the coordinated specialty care programs, which are programs designed for psychosis that are here in Northern Virginia. Next slide. So a little bit of background is that in July of 2014, the State Department of Behavioral Health and Developmental Services released a request for proposals to community services boards to solicit applications for funding to develop and implement evidence-supported early intervention and treatment models designed to address the needs of young adults, including those with first episode psychosis. The state identified 8 agencies who have since developed their programs to bring this evidence-based practice to Virginia. So in our area, of those 8, we are fortunate to have Alexandria, Fairfax, Loudoun County, Prince William County all have these first episode psychosis programs. In addition to that, the Rappahannock, Rapidan, Henrico, CSBs both also have it, as well as Highlands and Western Tidewater Community Services Boards. So a little bit about what first episode psychosis is. First episode psychosis refers to the first time that someone experiences psychotic symptoms. Individuals that have experienced a first episode may not necessarily understand what's happening to them. Symptoms can be disturbing and very unfamiliar for them, and it can leave the person very confused and distressed, and sometimes they don't even remember what's going on. It's usually unclear during a first episode as to what will happen with the symptoms over the long run, and if the early problem will develop into something that's more of a long-term issue. Psychosis typically occurs in 3 phases, and the length of each phase, as well as symptoms, vary from person to person. So if you're looking at the early signs or symptoms that an individual may experience, it's what we call the prodrome. Those are the early signs that might be very vague or very hardly noticeable. And And it might just be changes in the way the person describes their feelings, their thoughts, or their perceptions. Sometimes this looks like the individual may not be as socially outgoing as they were previously. They may sometimes appear almost depressed, or they may start to indicate some strange experiences, such as hearing buzzing or hearing noises that might not necessarily be there, or being suspicious. What you would see in this stage is that individuals may be asking for clarification a lot more. They may be double checking with you as to whether or not this is something that really happened. During phase 2, which is considered the acute phase, it's when there's very clear psychotic symptoms that have developed, where a person is experiencing hallucinations, delusions, or confused thinking. And then phase 3 is what we call the recovery phase, because psychosis is treatable and most people do recover from these episodes, but the pattern of recovery varies from person to person. Some people may only have a short duration of episode. Other people may experience this repeatedly over time. So each of the programs, as mentioned, were made in conjunction with the state, and there are similarities amongst the different programs. So all the programs required that the onset of psychosis to have occurred within 2 years of admission to the program. They all include what we call coordinated specialty care services. So it is a full array of services that an individual gets when they come into these programs. A lot of times what that looks like is case management, resiliency training, which might be a type of therapy that they might experience. They also offer supported education and employment services, peer recovery services, medication management, and a large component of these programs is family psychoeducation. All the programs meet with individuals where they feel comfortable. For them, it may be in an office or in the community or at their homes. So it's not necessarily your typical therapy that they may get. It's much more based on what they want and what their goals are. And lastly, all the programs are voluntary. The person must be willing to work with the team to meet their goals. But again, that looks different for each person. It's all based on what their goals are, and some people may need a bit more assertive outreach to really engage in the program. So now we're going to go into a separation of like what each program looks like. And I'm going to turn it over to the Alexandria Trails program, and Joanna's going to talk about that program.
So like Amanda said, we all have similar components. Like we all have peers and Cs who help with supported education and employment, as well as therapy and case management and medication management. Some of the differences that Alexandria does, slightly different, is that we will take the affective disorders. So that's like bipolar or depression, as long as there's some psychosis that comes along with it. And so because we're through the Alexandria Community Service Board, we are limited to the jurisdiction of the city of Alexandria. And we have kind of expanded our age range. So we will go as low as sometimes 15 and around 30 is our maximum age, give or take. And one kind of unique component of the Trails program is that when we wrote our grant, we knew housing was a difficult thing for a lot of residents, especially people who are just developing, mental health symptoms and psychosis. And so we have a portion of our grant money that we can help with rental assistance. So we're able to help people stay in their homes and stay stable so that we can really then work on some of getting back to school and back to work, things like that. So that is one of the different components that we have at Alexandria, is we have some designated funds for housing.
So the Fairfax program serves individuals between the ages of 16 and 30. Unfortunately, because we serve a large population, we are not able to serve individuals with the affective psychosis. So we do not specify, we do not serve individuals with depression with psychosis. And if it's clear that the person is experiencing bipolar disorder with psychotic features, then we would not serve those individuals as well. I will say that when we do our assessment process, if it's unclear, we may consider taking the person into our program to help us clarify that diagnosis, because there is variations between the two and treatment can vary. So we serve Fairfax County, the cities of Falls Church and Fairfax, and the towns of Vienna and Herndon. One of the additional programs that we have within Turning Point is that we are the only program in the state that has a component for individuals at risk of developing psychosis. What that looks like is we target those early warning signs. We also look at individuals who might experience a genetic risk. So that's somebody within their immediate family, parents, possibly grandparents or siblings that might also have experienced psychosis. We also look at individuals that have experienced brief episodes of psychosis. So in that at-risk for psychosis program, we can serve individuals between the ages of 14 and 25. And the goal of that is to identify anybody that might be at risk or getting to them early when they have the early warning signs of psychosis. Again, we have a pretty in-depth assessment process to help clarify that. We really try to work with the schools to identify as many individuals as possible through that process. The at-risk for psychosis program is different from the coordinated specialty care in that it's less intensive, and most of the individuals that are engaging in that program are distressed and seeking help. So it's more of a once a week outpatient type therapy that they would get.
So our program serves individuals who are residents of Loudoun County, ages 16 to 30. Our program is a partnership. It's housed within MHSADS, which is Loudoun County's Community Services Board, but the program is directly operated by PRS, which is a nonprofit organization that serves individuals with mental health, substance abuse, and developmental disabilities. In our program, we also take individuals with affective psychosis. So in addition to schizophrenia or schizoaffective disorder, we will accept individuals with bipolar 1 disorder with psychotic features or major depression with psychotic features, as long as the psychosis is the primary concern for that individual. In our onset of psychosis, the time frame between when symptoms first emerge and when they can start services with us is expanded a little bit. Ours is actually 3 years. So an individual would need to have started experiencing symptoms of psychosis within 3 years of their admission into our program.
Hi, yes, I'm Sophia Lenk with Prince William. Our program is very similar to the others that were mentioned today. We do have the C's and a peer and a designated psychiatrist and actually a designated nurse that helps with the participants' dietary needs or medical needs. Or health and wellness exercise, things like that, putting a customized plan together for them, and even going out to work on community with them as well. Of course, a primary therapist and case management as well. We take in participants who have affective disorders, so not just schizophrenia or psychosis only. We serve Prince William County residents. That's part of Manassas City, Manassas Park as well. Let's see what else is important to know. The psychoeducation and the support groups for the families. And, the participants also sees the staff in office, in their home, or in the community. So that's where we all are alike in that regards. Our age range is 16 to 25. Trying to think what other unique that might be different than what you've already heard. But I think that sums that up for Prince William.
Thank you each for going into your different programs and what they cover. And we received some questions from the community in relationship to the programs and in relationship to first episode psychosis just in general. And some of these you answered, but some of them maybe we can expand on. One was, what are the age limits? And it sounds like they vary depending on the program. So depending on which area or location they are in, that's the overall picture. I don't have where the person is from, so I can't exactly pinpoint for this particular question. Are there any plans to expand to include bipolar 1 for the program that does not currently cover it by chance?
So for Fairfax, like I mentioned, we really kind of look at that assessment process. If it's very clear bipolar right now, we would have to say no. We have been talking about it. Again, it's an issue of staffing at this point. If we had more staff, then there's the potential that we could serve more individuals. Absolutely.
Okay. Thank you.
I would encourage you to continue to advocate for within the county and talk to anybody that will listen about whether or not you would like that.
Thank you. So the next question is, what happens after 2 years in the program?
Well, in Prince William County, since we all have in the state have an awareness that 2 years is never enough, not enough, and internationally and nationally, we've discovered it is not enough time, there is an extension given, and an extension of the treatment plan timeframe. So we will, in a sense, play it by ear to see how far we are off from meeting the goals. Oftentimes it takes the first 12 months to get the medication balanced right, stable for these young folks. So there's a whole year missing with regards to them reaching their goal in a stable state. It is open in Prince William County. We have a 2-year program, but they do not leave in 2 years if they're not ready and if they have not met their goals.
Okay.
I think it varies from, I think, person to person too. You look at somebody who maybe had a shorter period of time where they were easier or maybe a little bit more open or willing to engage in services. We've had people finish in about 1.5 years. They've just kind of gotten everything they've needed from the program. And then like Sophia was saying, some people take a little longer. Sometimes there are interruptions in treatment. Sometimes engagement takes a while. Sometimes we're working with people for 6 months to 1 year on just getting them to see us, let alone actually doing any, real treatment, so to speak, even though the engagement is a big part of the treatment. So it varies. I know for our program, we can look at doing an extension if somebody has had a significant interruption, like long-term hospitalization, a period where they disengaged for a while, but then wanted to come back. So that's an option for us as well.
Okay. Thank you for expanding.
For Fairfax, I would say similar to both what Sophia and Lisa said, is that we can offer an extension. What we really look at is whether or not this is the right time for an individual to discharge from our program. Have they participated in the program, got as much as they could out of it, or are they still like just learning about psychosis, still developing those coping skills? We also will kind of look at whether or not where they're at in school. If somebody is just getting ready to start their first semester of college, we might continue to work with them to help get them over that stress of starting college, and just so that they kind of get used to it and make sure that they have that support there for them. And what usually happens to individuals when they discharge from our program, Most individuals will go to a less intensive program. We see individuals that will end up going to private providers in the community for just medication, or they might continue therapy afterwards with a private counselor or social worker. We also do refer individuals within our agency so that if they are on a medication that's difficult to prescribe by private providers, in particular Clozaril is one of those medications that's difficult to find private providers for, we will refer them within our agency so that they would just get case management or medications or therapy from our agency as well. But most individuals end up going to less intensive treatment after they end the 2 years with us.
Okay. Thank you for summarizing that. At what ages do first episode psychosis events occur? And maybe this could go to Dr. Jindal, I'm thinking, if you'd be willing to share.
Yeah, thanks, Christine. So it varies. Most people usually experience their first symptoms within this range of age that we are accepting in our programs. But unfortunately, psychosis is one of those things that can happen at any time. But we most commonly see it within the ages of, I would say, 14 to 30.
And then one of the questions was, why does the program stop at 25 or 30?
I think that goes back to just when we experience psychosis, usually at the first time.
Okay.
So usually people in their late 30s or 40s or 50s have already experienced psychosis before, and our program is really targeted for early interventions.
Okay. That makes complete sense. Who is most likely to experience a first episode psychosis event?
I would just kind of say that psychosis doesn't discriminate based on gender or socioeconomic status, that psychosis touches everybody. And so I don't think that there's necessarily one person that might be more likely to experience it. What I can tell you is that there is some research out there to indicate that individuals that use substances may develop psychosis, may be more likely to develop psychosis. So that would be one thing to consider. If somebody is experimenting with drugs during their high school years, that might make them more prone to experience psychosis.
Okay. And that actually leads into the next question we had. It is, how are first episode psychosis events different from PTSD hallucinations?
So I can take that one. People who suffer from PTSD have undergone a traumatic event. And usually when they have symptoms such as nightmares or flashbacks, or they can't even have auditory hallucinations, it usually relates to the trauma that they've experienced. So for example, someone who's undergone a sexual assault, they might have an auditory hallucination of the perpetrator of the assault. So in that way, you can differentiate the psychosis because it's a lot of times related to the trauma.
Okay. Thank you for that. One question we have is related to participation in the program and the voluntary piece. So assuming the individuals must volunteer to participate, how do you engage young people who may not want to participate?
I mean, we do lots of different things. We will call them, text them, show up at their house, go to get food with them sometimes, go to the school, sit with them. Sometimes, figure out what they're interested in and start talking about some of those things. And then a lot of times that can start building the trust and the rapport, and then they might be more open to actually talking about what's going on. So we also have a peer support specialist on our teams, which really help with engagement, and they can relate to people who have had similar experiences and symptoms. And so sometimes the peer can really relate differently to a potential new client or somebody who's experiencing distress that maybe a clinician just can't, or it's definitely different. And so we definitely have a peer on our teams that are able to kind of relate with clients and reach out and do an engagement themselves, which is different than how we would as clinicians.
And that is the benefit of having a team approach, that we have many different specialties and not everyone is going to click well, and someone is going to have that better rapport. So whether, like Joanna said, it's the peer, it could be actually the doctor, it could be the primary therapist, but it is a variety of interventions of specialties that one of them will likely have the better rapport build.
And
I think sorry, go ahead, Amanda.
I was just going to say, from my experience, we work very closely with the families, and maybe Stephanie or Harrison could talk about their experience as parents, and kind of knowing that not necessarily a child or a teen or a young adult would want to work with our programs, and trying to get some buy-in, what we are willing to do to try to encourage them to work with us, meet them where they're at.
Well, our child, number one, was very interested in getting a job. He had graduated from college. And so because you had the supported employment services, that was perfect, because he wasn't quite ready to have a job at that point because his illness had just started. But because of that motivation, he wasn't so interested in therapy because he didn't think he needed therapy. And he was taking medication at that time, although I don't think he really was tied to that either. But that was what he was very interested in. And even as he kind of stopped taking medication for a while, as most people do, I think, in the course of those first 2 years, even then he was still engaging with the job counselor. And he also engaged with his therapist. But it was really the job counselor that brought him in, wanting that. So that was really valuable to us. And having that team so that, he talked to his counselor as well as the therapist, but he knew that his counselor knew that he wanted a job and was helping him with that also.
Stephanie just kind of made the point that I was going to make, that taking medication is not a mandatory part of our programs. We really empower clients to make those educated decisions for themselves and make a decision of what they want to do in terms of their treatment. And we will continue to meet with them. Even the psychiatrist will continue to meet with clients, even if they decide not to take medication. But clients are really empowered to decide what treatment looks like for them.
I think that was important for our son, and he was very wanted to have as much control as he possibly could. So that was hard on us, but I think on the long run, good for him.
Thank you for sharing. I think it shows the strength of the coordinated approach and the person first. Just having that approach to the individual who is receiving the treatment can really lead to success. We have a couple more questions. One is, why do most doctors not want to take new patients? Is the system overwhelmed?
I'm not sure how to answer that question as the doctor on the panel. I know for these types of programs, there is, an eligibility criteria that everyone has to go through. So once somebody goes through all that criteria and they are entered into the program, then they will automatically get to see a doctor. Yeah, I'm not sure if that question is in regards to private practitioners versus like the community mental health system or not. So it's probably very different in the private sector.
Okay. Thank you for that. And we have the next question is, how many clients does each program serve?
So I can start off for Fairfax. We can serve up to 50 individuals in our program.
Alexandria can serve up to 40.
Loudon, we can serve up to 60.
And Prince William can serve up to 30.
Okay. Thank you. I'm just scanning through. We received some more questions as we were talking, so let me quick look at those. We don't have anybody from Arlington on the panel, but is anybody aware of the Arlington piece? I have a few questions about Arlington, their locality.
Arlington doesn't have made a CSC model like from the grant. What they did was they chose to do a young adult program. And so they provide, they have a coordinated,
Anybody
it's based
from
off
Arlington
of our model.
on the panel, but is anybody aware of? I think there's somebody might be listening to the on a different. It's okay. You can go ahead. I think now.
So they have a slightly different way of doing program. So it's not a grant funded like we are. They have similar roles, but they have expanded to all various mental illness, not just psychosis for Arlington.
Okay.
And I think it's like 18 to 25, and it's through their CSB.
Yeah, I believe their program is called First Step. And as Joanna mentioned, they do not have the same necessarily model as ours, but it's targeted for first episode psychosis. Theirs is much more broad, so that they can serve more individuals.
Okay. So I think that answers the other questions in relationship to Arlington that we received. There is one question about, are these programs funded in whole or in part by the Commonwealth? And you had mentioned all of the programs were grant funded.
Correct. So we do receive grant funding from the state. It's called mental health, like set aside funding is where we get the majority of our funding from. Now, each CSB does have the opportunity where they could, in partnership, provide additional funds as needed. So like Fairfax County does offer to provide some funding for us as well. Our At Risk for Psychosis program in Fairfax is fully grant funded, and that's grant funded through SAMHSA.
Okay. Thank you. For the Loudon program, is there a service location in Loudon County?
Yes, so our office is based out of Leesburg. It's located within the mental health center in Leesburg, and then we also have an office location in Sterling as well.
Okay. So those are all of the questions that we have that came in. I do want to give another opportunity for Stephanie and Harrison to speak about their experience with the program. I feel like the community would really benefit from hearing about the experience.
Yeah, it was, so first of all, we don't have a breadth of experience here, so we don't know what it's like not to be in the program. But because we got in pretty quickly. However, it was absolutely just, it was a godsend for us to have this program that had multiple services that was kind of taking our child by the hand, but also taking us by the hand. And one of the big things for us was the parent support group they had, because that helped to meet other parents going through this awful experience and kind of have kindred spirits, but it also had parents who were farther along in the program, and you could see how progress was being made. And it was also, of course, the therapists and other people in the program educating us about this disease and about the way they handled this disease. So we kind of understood some of what our son was getting. Because our son, because he was older, he wasn't, and very independent, he wasn't coming home and talking to us about it. We didn't go with him to therapy or psychiatry meetings, except for one exception or two. And so it was really good to understand what Turning Point was doing by going to the parent support meetings. And there were other activities which he didn't participate in, but I think everyone had their own kind of things. And with our son, it was the job thing. So.
Yeah, I want to add to what Stephanie was saying, and I think that underline that the initial month is the toughest because you have no clue what's going on. And we were super disorganized, discombobulated by what was happening. So getting our child into some kind of therapeutic setting and then dealing with the back and forth about that. And at some point, I would say after a few months, things took. But that initial phase where they're not taking, and there's certainly a lot of fear and concern and stress and anxiety and turmoil. It's very chaotic time. So I would urge anyone, to don't wait, don't sit there in the chaos, but reach out and get the professional help that you need, because you can't figure this one. If someone gave us the advice, and I think it was really good advice early on, don't look for an option that is unstressful. Anything you do is going to be painful, so just go and do it. There's not an easy way out of this one. And there wasn't. If anything you do is terribly hard, but it's necessary. So having the support of the Community Service Board and Turning Point was essential, and especially at different points of the process, the hospitalization and getting some kind of stable structure in place. That's very delicate times. And a very frustrating time. We know how difficult it being in the support groups, hearing how many tries people have had, have gone through, trials people have gone through. So, my heart goes out to everyone dealing with this issue. And but we hear some people waiting, and we just would say, don't wait. There's just you just have to confront it, and don't look for an easy way out. There isn't one. But get the support that's there. That's the fantastic thing, that the support is there.
Okay. Thank you for sharing. It looked like Stephanie, maybe you were going to say something in addition.
I think Harrison might have pretty much said it, but one thing that we loved about Turning Point was that the anosognosia is the not recognizing that they have an illness, that you have an illness. So because they don't recognize they have an illness, they don't think they need treatment, and that can be such a block. But Turning Point was willing and ready to come out to the house. It turned out didn't need that. He ended up going there, but they were saying, that's all right if he doesn't want treatment. We're still gonna treat him however we can treat him. And that was just amazing and wonderful, because I don't know. I would imagine there are programs that don't work like that. And that was necessary to get him into the program.
Thank you.
For me, I think for me, it's hard to believe that Stephanie and Harrison have been participants in our program for 2 years already. It seems like that time has just kind of flown by for us. And I remember my first meeting with Harrison where it was like, we don't think we want to start your program, but we'll give it a shot. And we were kind of like, just let us try. Because we are all very well versed in that assertive outreach process where we are trying to find our in, where can we meet with this person that they want something from us. Sometimes we do have to get parents on board with that and setting some limits of, well, I'm not going to pay your rent unless you meet with this person once, something like that. We're kind of encouraging, and we do as much as we're able to, given HIPAA, we will talk and coordinate with families and give recommendations. We encourage all of our families to attend. For Turning Point, we do a parent support group that is twice a month. The first session is education, where we really focus on giving parents the tools to so that they know what they're dealing with. And then the second part of the month, we try to do more of a process base where we're talking about your experiences, and other parents are able to kind of elicit feedback and kind of say like, yes, you're on the right track, or, I tried this and it didn't work, but maybe it'll work for you. And so we really try to encourage that family support group, even if the individual is not letting your therapist talk with your parents, then we're still at least trying to have some connection with the families regardless.
Okay. So how do I know if my child is experiencing symptoms of psychosis was a question that we had received.
Well, as we spoke earlier, the prodromal phase can look a lot of different ways to different people with regards to changes in appetite, emotions, thinking, and the behaviors. Decreased energy, motivation, difficulty functioning, and social withdrawal seems to be a common thread for most of our young folks. Not to say any one of these things means that something is going to be activated or develop, but those are things we watch for. And we would hope parents anyway would seek out consultation to say, is this something I should be worried about? Because yes, it could then develop into an active psychosis. I'm going to let Dr. Agenda to continue.
No, you did a great job, Sophia. Yeah, the other thing I would add, a lot of times we see people's hygienes and attention to appearance change. So somebody who was showering every day and cared what they look like is no longer doing that. That's a big sign for me that something's not going the way it should be. I think one great thing too about our programs, and I can speak for Fairfax County and City of Alexandria, we try to get into the schools to do some education there, because a lot of times it'll be the teachers and peers that will notice that something's not right or something's changed. So by providing education about things to look out for to those people who come into contact with the clients, we can increase the exposure to people realizing that there's something not right going on.
And I would also say, so if you have concerns as a parent, I would encourage you to reach out to our programs and ask us to take a look and see if this might be appropriate. For Fairfax, we have some screening tools that we can offer as a parent that you could take one of our screening tools. And if you think it's a match, then we can go through our eligibility process. But I would encourage you not to, like Harrison said, you have to act as a parent. Go ahead and reach out if you can, if you have concerns, whether that's just going through, like each of our agencies has an entry and referral option where you can go in through there, or you can reach out to our programs directly to see if it might be a psychosis related problem.
I think one of the items that you had mentioned, or the characteristics of the program, was that the outreach in relationship to connecting with the individual, is that something that's limited to the first episode psychosis programs at the CSB, or does that extend past that first episode psychosis program? Does it depend on the...
There's a number of programs within at least Fairfax County CSB and City of Alexandria CSB, and I'm assuming the other CSBs as well, that do a lot of community outreach and home visits. There's something known as the Assertive Community Treatment Team, where 80% of the work is supposed to be out in the community and at patients' homes. There's other teams like intensive community treatment teams, jail diversion teams that provide a lot of in-home services and community services.
Okay, thank you.
We, in the very beginning, in the first few weeks, we called Fairfax County's emergency services. I'm not sure what exactly the name, crisis and emergency services. And we had, I think, 2 or 3 people come out for evaluation of him. And basically they said, well, you know, yeah, there's a problem here, but we had to we didn't know about Turning Point yet. So, but
Okay.
then that's how we found out. I think that's how we found out about Turning Point.
Okay.
But yeah, there was a crisis line that we called.
I think a big component of all of our programs in particular is the amount of outreach that we do and the sources that we look to provide education to, because I think all of us were trying to gain that early intervention piece. So it's not easy for people to, especially for people who are brand new to having any kinds of experiences where they need to seek out help. I think, unfortunately, it's not always easy to do that. Plus, when you have that added stress of everything that's going on, it's hard. So the more outreach that we can do to try to get the word out to as many referral sources as possible, the easier it is for families to find us when they're in their own time of crisis. So that's huge for, I know definitely our programs all focus on that.
Mm-hmm. One question that came in was related to back to the funding. Is the state still giving out grants for FPP programs? Our first episode psychosis program. Sorry, I used the acronym there for a second.
I don't believe that they are.
Okay. And then the next we have is, how can I support my child as they are going through a first episode psychosis program?
Well, this is a very difficult time for families. It is frustrating for the individual experiencing it. They don't know what's going on with them typically, and the parents don't know. And we've heard from Stephanie to tell us about her experience as well as Harrison's experience. And it's a frustrating time, and we have to acknowledge that to them. And just like the parents on this panel explained to us how our intervention, Turning Point's intervention, helped them and pulled them along and gave them the tools they need to understand what's going on. What we all have been trained to do is acknowledge that each time we're encountering a new candidate, a participant, someone who wants that person in our program, because it's not always the individual themselves, and to just get our foot in a crack, to give them some kind of hope or give them some thing to draw them to us, because we want to help move them forward. We know our program is excellent. And with that team approach, the coordinated specialty care with all those specialties, we want, to do something to get them convinced and convince the families that we want to work together. And it's a difficult little dance when the individual has not come to an awareness that they do need help, that there is something going on. But there's many different interventions, and it can be just, you want a job, we're here to help. And then all the other things can flow into place later on. So just first off, acknowledging the stress and the frustrating time at this very beginning of an episode.
I'm going to add something to that, and it occurs to me, it's a cliche, but the old thing about put on your own oxygen mask first. And that was essential, the support groups, getting grounded and getting knowledge, understanding what's going on, getting some understanding, and not taking it personally. I mean, it's something else going on. It's not a reflection of us or you, or just not getting reactivated and being your own island of calm. And that's essential, I think. taking care of yourself and each other, Stephanie and I taking care of each other, and then we could do a better job of taking care of our child. But finding a way to attend to that need for support, community, knowledge, stress management, going for a walk, whatever it takes to help appreciate the fact and be compassionate to yourself. Oh man, this is the worst situation just about any parent can go through. And so be kind to yourself. You're going to be super stressed out. Just recognize that, and be really, really, really kind and generous and compassionate to your partner and each other, knowing that the more you can lean on each other, the more you can do for your child. But that's where it starts.
Thank you.
And I think the Harrison, turn off your mic. To remember that this is not personality. These are symptoms of a horrible disease. This is a brain disease. This is a neurological condition. It is not a moral failing or some kind of frailty. It's a disease, and this is symptoms. And even sometimes when my son was showing some symptoms, I would just say, these are symptoms. These are symptoms. This is a disease. This is not you. And, to just, we let him know we loved him and we were here for him and we had his back. And maybe sometimes we were doing things that he didn't like trying to get him treatment or when we were trying to get him hospitalization. But we were always letting him know we were there for him. And the other thing is we did do other support groups and I did find confidants in my friends. I didn't tell everybody because it was his medical information that I didn't want to just share willy-nilly. And there is a sensitivity to that and a stigma to that as much as we don't want it to be, there is. But I found out who my true friends were because they were the ones that I could tell about this. And, so we didn't advertise it, but we didn't try to cover it up. And that's challenging.
Thank you for the share.
I think I can add one more thing. Pardon me if I'm going on too long. That I think one key thing was in the interaction, especially early on, not wanting a child to be better so we could feel better, but having enough detachment, okay, he's not feeling good for him, he's not feeling good for me, but let me give him some space because I don't want to be coming from my needs.
Okay.
Really self-management. There's a lot of self-management and self-awareness. When I'm about to interact, where am I coming from? Is it coming from some kind of coping mechanism to contain my own anxiety, or is it coming from something that really is helpful? So you have to really ask yourself a lot of questions before you act.
Thank you for that. I appreciate it. As we wrap up, so we have about 5-6 minutes left. Do we want to do a final piece of advice from everybody for parents or educators regarding first episode psychosis? Based on the questions that came in and some of the conversation that we had tonight.
I would just say my final advice is as a family member or even as an individual, go ahead and reach out to our programs if you think that there's something that might need to be seen or might want to have checked out. It's better to go ahead and reach out and let us help guide you in the process. And I would also say, that one of the big components of all of our programs is encouraging families to understand that just because an individual has this illness, that there's still a ton of hope there. The majority of our folks, by the time they end our program, are either working full-time or part-time or are back at school, completing college. So we really focus on this functional recovery and what that looks like.
I think my advice, my final parting words would be just around medication. I know when you read about these medications, they sound so scary with all the side effects. And to be honest, they have some terrible side effects. But I think most of the doctors that work in these types of programs, their goal is the same as everyone else's goal, which is for people to be on the least amount of medication as possible. So even if you don't think medication is for you or for your family member, still meet with a doctor and see if there's anything that they can do to help. Just be open to the idea that a low dose of a medication might be really helpful.
This being a parent is and being a patient or client is it's a twisty, turny path. There can be, things go well and you just think, oh, thank goodness, yes, and then boom, something happens and it, goes the other direction. But each time it's going in a direction, you just know it's going to keep twisting and turning, but it's also going to get better.
Thank you.
It just might take longer than you want.
And we have to look at those little successes. And that keeps us all going because we want to see that. Someone who hasn't stabilized on their medication in the first year or year and a half finally is stable and finally can get that job where it looked like maybe they were going to a higher level of care, like the PAC team, the ACT team. And it wasn't the case. So just those little increment success stories that can just give us all that hope and also have us recognize everybody's success story is different and it looks different.
Can I say one more thing? Sorry.
No, absolutely.
Say too, psychosis is not a death sentence. There's no reason why you or your family member cannot have the life that you want, get married, have children, have the job of your dreams. There is absolutely no reason for that not to happen. So stay hopeful.
Yeah, and I would agree. We've been in rooms with a lot of people who were beginning in the same place we were at, in a very unhappy place, and then 2 years, 3, down the road, things improved for many, many people. We were, and just so that happens. It happens. There's definitely don't lose hope.
And I think just all of us coming together, it's a community, whether it's the other families, the other clients, the hope is there. And I agree, we have such successes with our clients. They're all back at school and working and things. So I think hold on to the hope and use the community and reach out to us because we can help guide you and walk you through the steps. I frequently send and call Amanda or Lisa or Sophia and link out to other places when we get phone calls. So we are a community, even though we are different providers. So there is help and we're willing to work together to help.
And I want to say thank you to all of you who work in this field and have basically been here paving the way for us. I mean, I'm just going to cry. I'm so grateful.
I think
Thank
we need
you.
to send you virtual hugs.
Thank you, everyone.
Thank you so much. I want to say we just have 1 minute left. Did anybody else want to have a last thought before we wrap up? Okay. I just wanted to say thank you for our panelists for joining us this evening to talk about this. It's a difficult topic and it's difficult to go through, whether you're the individual living with the condition or a provider or a family member or caretaker. It's not always easy. So I love the message of hope that we ended on. So I'm going to end on that and just spreading the hope out there and don't give up. Keep going, just one baby step at a time forward, even when you have to take a step back. That's all you can do. So thank you, everybody, and I hope you have a good night.